Assalamu alaikum and welcome back to another episode of What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and I'm a board-certified physician. My show, What's Up, Doc, is a production of Muslim Network TV, the only Muslim-focused network broadcasting in North America. Today, we're going to be talking about a really exciting episode, and it's about a topic that a lot of us may have experienced in the past, and that is urinary or kidney stones. Joining us in that discussion is Dr.Naeem Rahman. He's a board-certified urologist and medical director of urology at Atlantic Medical Group. He treats a broad spectrum of diseases and disorders of the urinary tract, particularly urological cancers in men and women, with the goal of restoring normal function and improving their quality of life. After earning his degree from Wake Forest University School of Medicine, Winston-Salem, North Carolina, Dr. Rahman completed residency programs in surgery and urology at Eastern Virginia Medical School in Norfolk, Virginia. He is an assistant clinical professor at New York Medical College, Valhalla, New York. Welcome, Dr. Rahman. It's a pleasure to have you on here today.
Thank you for having me. I really appreciate the opportunity.
Absolutely. We're really excited to talk about this subject because, as I mentioned, a lot of people unfortunately have been affected with kidney stones or know somebody who's been affected with kidney stones. So I think it's a great topic to kick off and talk about. Before we get started, let's talk about what are kidney stones. For those who are lucky enough to have no experience with it, what are we talking about when we say kidney stones?
So in simplest terms, it's just the mineralization of salts that occurs in the urinary tract. It's a basic chemistry experiment. You have salts that the urinary system is trying to get rid of, and that's part of the waste of urine. And when the concentration of certain minerals gets exceedingly high, i.e. calcium or uric acid or citrus or any of these things, those minerals crystallize out of the urine and become a mineral. And when that mineral grows, it becomes a kidney stone. So it's your basic chemistry 101 crystallization of minerals out of a solute. So, but to your point, when these stones do occur, and we're in the midst of stone season right now in the summer, they are very, very painful. Amongst the worst pains there is in medicine. So it's not subtle. So, it's important to know what the signs and symptoms and what the preventive tools are for this, because it is a significant source of pain and problem and discomfort. But fortunately, it can be prevented as well.
That's good. And we'll get into that definitely later in this episode. So as far as the pain is concerned, and again, we'll get into the signs and symptoms, but I've heard it being said, of course, by men, that the pain is similar to that of childbirth.
I've had women patients say it's worse than childbirth.
It's worse? Oh my God.
So yeah. So, any deep visceral organ, when it's stretched beyond capacity, creates this extraordinarily pain. I mean, when women have birth, their uteruses are stretching and it creates a real extraordinary pain. So what happens with kidney stones is that the kidneys are purposed to excrete urine down to the bladder. So when a stone comes in the urinary tract and blocks off the kidneys, urine is still being made and urine is still trying to get out of the body, but then it meets this kidney stone and it creates an obstruction in the urinary pathway. So urine starts to back up into the kidneys and it's still being produced, but it's starting to back up. And so what happens is that the kidney stretches and stretches and stretches, and it creates a horrible pain. So it's not actually the stone itself that's causing the pain. It's the byproduct of the obstruction that causes the pain. And that's similar in gallbladders. When the gallstones obstruct the gallbladder, it's horrific pain. So the hallmark of really deep visceral organ stretching is significant pain. And kidney stones are amongst the worst pains that people experience.
Wow, yeah, thanks for that visual. It does explain a lot of the pain that you're describing, and that's good to know because a lot of people do think that it's related to the stone itself. I mean, of course, the stone being there is the impact of that stone being there is really what's causing that pain.
Right.
You mentioned that these stones are formed as basic chemical reactions. Are these cause the different chemicals that form these stones? Are they from things that, and of course, I tell my patients this, but from everyday things, or are there things that maybe they're consuming that is detrimental to their health, unbeknownst to them, and that's causing precipitation of the stone to form?
It's really a combination of all those things. So, being that the summer is when we see the highest incidence of stones, the biggest factor is dehydration.
Yes.
So, and the stone belt is really the southern part of the United States. The southern part down to the southwest, and that's correlates with
Extreme heat.
with heat and dehydration. So, the biggest thing we want people to do is stay hydrated. And if you have a history of kidney stones, that should be a real conscious effort to keep hydration even beyond what you think you should sometimes. So, one factor is what you're not doing, and that's drinking enough. There are many, many other factors. Obviously, calcium-based stones are a big part of stones, and sometimes patients are inadvertently consuming too much calcium. I think, unfortunately, part of the issue is sometimes we in medicine have pushed calcium diets and calcium supplements on a lot of patients. And sometimes they already have plenty of calcium in their diet. And as a result, that extra calcium is going to contribute to forming stones.
Yeah, that's an interesting point, Dr. Rahman. I'm sorry to interrupt you, but there are, with regards to calcium, does the intake depend on the kind of stone a person is having? Because in some respects, I've heard that increasing calcium, depending on the kind of stone, may help to prevent certain stones from forming. So
Right.
maybe we can take a step back and talk about the different kinds of stones that exist. And as you mentioned, the different chemical reactions cause these different kinds of stones, so that we have a better idea of what are the different minerals that are involved in these stone formation.
So calcium-based stones are the most common. The most common stone is calcium oxalate, and oxalate is a byproduct of a lot of foods, a lot of things in our foods. It can also be a function, excess oxalate can also be a function of a lot of gastrointestinal disorders like Crohn's disease, like history of gastric bypass surgery. All of those things also promote excess oxalate in the urine. There are also some other more genetic causes of excess oxalate in the urine. But in general, so going that further, there are other types of kidney stones. There's uric acid stones, there's calcium phosphate type stones, there's infectious type stones called struvite-based stones. And so the pathophysiology, or the reason why people get these different stones, is variable. And even within each subtype of stone, it's not clear cut that one factor is always the overriding factor. So, for instance, you mentioned in some patients, we might want them to increase their calcium. Those patients are typically the ones who have elevated oxalates from a GI issue. For instance, if they've had gastric bypass surgery, if they've had some form of their intestine removed because of different problems like Crohn's disease, ulcerative colitis, those patients are going to be prone to absorb more oxalate than they need to. And as a result, they're going to excrete more oxalate in their urine. For those patients, we do tell them to increase their calcium to help bind it in the gut, so there's not as much to get rid of in the urine. In general, though, I would say that my own personal bias, and I'm emphasizing it's my bias, I think we do push calcium a little bit too much. As an antidote to this, 25 years ago, the incidence of kidney stones between men and women was almost, 70% men would, of all the stone formers, 70% would be men, and only 30% or so would be women. But because of the increase of calcium intake, particularly in some of our postmenopausal women, we're seeing those numbers becoming closer to 50-50. And I do think that is part of the factor. So again, every situation is different, but I think most Western diets, most people, unless they're severely osteopenic or have brittle bones, probably don't need a lot of extra calcium in their diet. And I think adding those supplements has increased the kidney stones. There are other factors, for instance, the uric acid stones. They don't have any issue with calcium. Calcium metabolism or how we regulate calcium in the body is really not part of that equation. That's strictly a function of how much protein is in your diet. So there are patients for whom protein is their main source of food consumption, and they're eating 3 and 4 portions of protein every day.
Especially with keto diet, patients who enjoy a keto diet. Yeah.
Keto diet, yes. And we do see increased risk of kidney stones with the keto diet. And we see those patients develop primarily uric acid stones, but uric acid elevation in the urine can also contribute to other types of stones. So that's part of the equation as well, is looking at how much meat, looking at how much salt is in the diet. So one of the things that happens with salt, if you take in a lot of salt, and it's not just the salt shaker, we have to be cognizant of preserved foods in a can, foods in a box. That all adds to the salt intake within our diet.
Sorry to interrupt you again, Dr. Rahman. And that's specific to sodium. And that's what I tell my patients as well, is that when we think about sodium, the common person, their average person thinks salt, but just like you said, and I have to specify for my patients, I said, well, I'm saying sodium specific. Yes, it's found in salt, table salt, but it's also found in, as you said, preservatives, canned foods, and things like that. So it's important to pay attention to that as well. So I
would add that, the healthy food that you make at home, if you had that same dish in a restaurant, you could probably add 2 or 3 times the salt content because of the preservatives that are added. So, when you do have a high salt diet, one of the things that the body does is try to get rid of the excess salt. And then going back to chemistry 101, calcium will follow the sodium. And then when you increase the calcium, then you're also, again, increasing your risk for the kidney stones. So one of the things we tell patients is also to look at the amount of salt in their diet. One other important factor that the patients and the audience ought to be aware of is that citrus actually can help combat the development of kidney stones. So citrus, things common like lemons or grapefruits or oranges or any of those kind of byproducts like citrusy drinks, sports drinks. If you consume enough of that citrus will get into your body. It'll go into the urine, and then actually the citrus will bind to the calcium and make it less available to become a kidney stone. So one of the things we often tell our patients, and one of the hallmarks of treatment, is that we encourage all of them to increase their citrus intake. And that's something that we emphasize just about every patient. So we try to give them 2 or 3 basic principles: fluids, hydration, cutting back on salt, cutting back on protein, and adding citrus to their diet as basic means to help reduce kidney stone risk.
That's awesome. When you mention citrus, does lemon water count, adding lemons or having lemon water in the morning? Or
absolutely, 100%, because lemons have the highest content of citrus. So, our go-to for patients is lemon water, lemonade. Anything that adds lemon to your diet is going to reduce your risk of kidney stones.
Awesome. So there's more benefit than just improved taste for people who don't like drinking plain water. So that's good to know.
Absolutely.
Now, I believe that most of our discussion so far has been in adults. So very briefly, can you touch on whether this is something that children are also affected by, just so that for any parents in the audience, it can be something that they're also thinking about for their kids?
So in general, kidney stones are pretty rare in really young children. I'm talking about elementary school children. However, we are seeing an increase with kidney stones in young adolescents, ages 15 to 17, 15 to 18. There has been a steady rise in stone disease in those patient populations. And I think it largely hinges on a lot of the things we've already touched on, predominantly diet, perhaps increases in obesity, which is probably a byproduct of some of the poor diets that we've talked about already. So in general, it's really rare for really young children to have kidney stones, but in our adolescent patients, we're seeing it more and more.
Okay, thank you for sharing that, Dr. Rahman. So we've talked about what are kidneys and a little bit about the risk factors. We're going to come back after this short break and talk a little bit more about symptoms and other things about the kidney stones that you might want to learn about. So stay tuned. You're watching What's Up Doc here on Muslim Network TV, and we'll be back after this short break.
A free online chat can give you the personalized tips you need to start boosting your retirement savings today.
Our fellow Americans.
Right now, the COVID-19 vaccines are available to millions of Americans.
And soon, they will be available to everyone.
The science is clear. These vaccines will protect you and those you love from this dangerous and deadly disease.
They could save your life.
So we urge you to get vaccinated when it's available to you.
That's the first step to ending the pandemic and moving our country forward. It's up to you.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3. You saved me. Dad?
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
We are Justice for All. Headquartered in the heart of downtown Chicago, Justice for All is a global humanitarian initiative dedicated to raising awareness for human rights concerns impacting vulnerable minority groups. Our diverse team of staff and volunteers, led by Imam Malik Mujahid, work tirelessly to help Justice for All achieve their goals. We promote policies that protect religious freedom, address the root causes of mass displacement, and recognize the plight of refugees and forced migrants. Together, we can continue to stand up for justice. Justice for all.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for help with food, healthcare, and other resources.
211, how can I help you?
Call 211 or visit 211.org. 211, get connected, get help.
Right here, baby. Look. Uma.
Noah.
Something more than a birthday is happening here. Once you can see it, you can help. The sooner you recognize the signs of autism, the sooner you can make a lifetime of difference for your child. Start by answering a few simple questions at screenforautism.org.
Assalamu alaikum and welcome back to What's Up Doc. I'm your host, Dr. Aalia Al-Barwani, and today we are talking about kidney stones. We're lucky enough to have Dr. Rahman here joining us to talk about this. So, Dr. Rahman, before the break, we were talking about the different kinds of kidney stones, risk factors that can lead to these kidney stones from forming. And one of the things that we had talked about was a high sodium content. Now, some patients may ask some in our audience may ask, where is the line? Where is the line drawn as far as how much is too much sodium? And that also brings the next question of, as we said, with canned goods and things like that, sodas and Gatorades and drinks like that, some of them are high in a lot of minerals and electrolytes, which may precipitate kidney stones. So again, where are we drawing the line there too?
So in terms of the latter question regarding fluids and the mineral content of fluids, hydration supersedes anything else in our mind and our experience. So whatever I can encourage a patient to do to increase their hydration status, I'm going to encourage that, even if it means that they have a slightly increased mineral content in their fluid intake. So hydration. That's really the biggest principle for kidney stone prevention. So if that means they're going to drink a little more Gatorade, I'll encourage them to make it sure it's a citrusy flavor. Sodas, I'm not so thrilled about, but again, the hydration part is really what we're looking for. So we could tolerate a little bit of that. That would be my first preference. But yeah, the first principle is going to be always hydration. It's that will take precedent over the salt content of things, in my experience. As far as the daily salt content, I wouldn't exceed the daily recommended daily allowance set aside by the different food industries. That number isn't coming to me over the top of my head, but I think we could easily find it.
Yeah, well, actually, that's a good point that you bring up, and it does vary depending on if you have an underlying condition or not. So right. I think it's best to always check back with your doctor, because if you are hypertensive or if you have kidney failure, then the value is going to be a lot lower. It can be 1.5 grams or as low as that, or as high as 3 if you have healthy kidneys. So it's probably best to ask your doctor so that you understand what is your limit then.
Right. What I found with patients also, though, is if you give them 5 or 6 things to concentrate on, it's going to be really, really hard for patients. So I really try to make it simple. I mean, I go over all the risk factors with all of them, but I really emphasize fluids and citrus, because I think it's easy to add lemon to your water every day. And I tell them if that's the only thing that they can take out of our conversation, then we're still way ahead of the ball game. So sometimes if you inundate patients with 10 different things that they must do, they're going to be so flustered and feel so overwhelmed that you may not accomplish as much as you'd like to. So I generally go over the risk factors, talk about the things we've discussed regarding salt, meat, fluids. But at the end of the day, I tell them, if you can give me a gallon of water a day with a freshly squeezed lemon every single day, particularly in the summer, then we've got something going. And if that's all you can do, you've done a tremendous amount.
Awesome, thank you. And we did have a little banner go across with the recommended, but again, that's not for everybody. It depends on whether you have a disease or a underlying condition. So definitely check back with your doctor. Now, we talked a little bit about some of the conditions that, and sorry, I'm just going back to what you said about just not inundating patients with a lot of information. I completely agree with you. Try not to have to, especially as a family physician, they're coming to me for all kinds of problems, not just one thing. And so our visits can get a little bit tricky, and I try to narrow it as much as possible, because just like you mentioned, it can get a little overwhelming. I'm trying to counsel you on each of the different things that you're bringing up. And so it can be a little bit of information overload. So I agree with you there. Stick to a few basics.
Right.
So back to symptoms, I guess, is what we should talk about next. You did describe to us in really good detail how and why some of the symptoms that patients who have kidney stones experience that due to the backup and backflow from an obstructing kidney stone. So let's talk about some other symptoms that a patient may experience that might alert them, or even their physician, that they may have a kidney stone forming or formed.
So, the classic symptom is pain in the flank, in the region of the kidney. So, and it's not just subtle pain. So we get a lot of patients with some mild back pain and things that they can kind of tolerate, and they're worried they have kidney stones. So kidney stone, as we mentioned, is not subtle. It's a really excruciating, gnawing pain in the side or the flank. So that's one classic symptom. The other classic symptom is that pain kind of radiates down into the groin region. So that's another sort of classic kidney symptom. The other things you can see is often patients may have blood in their urine, either what they can see or what their doctors see under the microscope. You can have some increases in urinary frequency. You can have a symptom of a urinary tract infection. So those are the common things that we'll see. You might think you have indigestion. You might think you have a GI bug or GI flu. A lot of times those are kind of the presenting symptoms to the emergency room, and we end up seeing these kidney stones.
Perfect. And just to clarify for our audience, when you say symptoms of UTI, I assume you mean painful urination, urinary frequency, meaning going to the bathroom several times with maybe low volume of urine.
Right.
So I like that. So it's really important if you have those symptoms to come in to be evaluated, because it could be a stone, it could be an infection. As you mentioned, the symptoms can overlap. But what's really important to understand is that the symptoms are not going to be light, so as you said, because I have patients who come in with intermittent, meaning pain that comes and goes over the period of months, and it's just a little bit of backache in their lower back, and they're like, well, I think I have kidney stones. And I'm usually like, if you have kidney stones, it wouldn't be, I think. You would, you will be in a lot.
It's not subtle. Kidney stone pain is pretty dramatic. And typically it's going to either make you want to go to the hospital or go to the hospital. So it's not something that you can kind of live with. It's not something that you can kind of continue your daily function with. It's going to be a pretty dramatic increase in your pain. Rarely we'll see patients with chronic bacteria in their urine, and the only thing we end up finding is a kidney stone that's large. Sometimes when kidney stones are large and they're just sitting in the kidney, they're not blocking something, they can be a source of an infection, even without causing any other symptoms. So I've had several patients, or many patients in my career, that they just presented with ongoing bacteria in their urine without any clear underlying issues otherwise, and we find a stone that's sitting in the kidney that's not really causing a lot of pain, much to their surprise, but causing other problems like an infection.
Interesting. That is very interesting. I'll keep that in mind. So as far as diagnosis, if a patient comes in and they have symptoms, you're fairly sure it is a kidney stone, what's involved in diagnosis? I've had patients ask me to do blood tests, and I kind of have to explain to them that really doesn't help us too much as far as diagnosing, and maybe other related conditions that put them at risk, but not necessarily diagnosis. So let's clarify what actually goes into diagnosing kidney stones.
Yeah, so the gold standard is probably a CT scan or a CAT scan, which is a radiological examination that takes cross-sectional pictures of the abdomen, including the kidneys and the entire lower abdomen and pelvis. That's typically one of the commonest ways we diagnose it. Typically, that's something that the emergency room has already done for us. A lot of times, by the time they end up seeing a urologist or the primary care doctor, there are times when an ultrasound is useful as well. Although there are times when an ultrasound will pick up shadows that may look like kidney stones, but the gold standard really is a CAT scan. So that's really the principal way of making the diagnosis.
Yes, I agree with you. I've had shadows on X-ray or ultrasound, but never really conclusive, usually not a conclusive diagnosis as with a CT scan, of course, coupled with a history and physical exam.
Right.
And so once a diagnosis is made, why is it important to treat kidney stones? What are some possible complications if we left kidney stones untreated, besides obviously pain, which we could argue, well, I'll give you something for the pain, but maybe we don't need to do anything about a stone. And let's talk a little bit about that.
So one take-home message is that not all kidney stones necessarily need to be treated. It really depends on the size and the location and what the
height, maybe
other medical health symptoms are. So if a patient is comfortable, if the stone is relatively small, and we have parameters that we look at, we will often give the patient several weeks to try to pass it as long as they're comfortable. So that's one aspect, is that not every kidney stone needs treatment. And there are times when we can follow them, and many times patients will pass these kidney stones on their own and they can avoid treatment. Then the next step is to try to figure out why they're getting it and talk about prevention. But if a stone is large enough, and typically, anything above 5 millimeters is considered a large enough stone where we might want to consider treatment. We talk about treating to prevent the pain symptoms largely. There are times when the kidney is also obstructed and kidney function is compromised. So that is also a potential reason, is to make sure your kidneys will work well and don't have any permanent damage from them. The other reason is to stave off a urinary tract infection. And again, you have to look at the whole patient. If you have a patient who's a little bit older, maybe a diabetic, patient who may be prone to urinary tract infections, then you probably don't want that patient to go a long period of time to try to pass a kidney stone. So that's there's no one cookie cutter answer. It's really tailored to the individual presentation, largely determined by size of the stone as well, and what kind of symptoms they have when they come and present.
Okay, thank you. And so just to kind of summarize with regards to complications, possibility for infection, and of course with our more vulnerable population, elderly, that can be something we want to be careful of, because that can of course turn into sepsis, and where you're now having this infection all over your body, not just limited to your kidneys. And then you mentioned some kidney damage that is potentially irreversible, I would imagine.
You'd have to go a long period of time for a kidney stone to kind of cause irreversible damage. I mean, you'd have to go perhaps 6 weeks or months on end with the kidney blocking your kidney, a stone blocking your kidney, to have irreversible damage. It would be pretty rare, but in theory, it could happen.
Got it. And what's the largest size stone that you've seen in your practice? I was reading something earlier about the world record, sorry to interrupt, but of the world record, and I think it was like 17 centimeters or something like that.
Yeah, those are big stones. I mean, I think the largest stone I've treated is probably about 6 or 7 centimeters, encompassing most of the kidney. But those are rare presentations. That's not common. But yeah, the largest is
good size. Yeah. Oh my goodness. Okay. And going back to our vulnerable populations, let's talk briefly about pregnant women or stones in pregnancy. Is there a different approach for pregnant women when it comes to stones?
Yeah, I mean, that's a great topic, and I think we could do a show in and of itself based on that topic. So the tricky part in pregnancy is that it's hard to definitively make the diagnosis of a kidney stone, because we're limited by our imaging technology, right? Because we don't want to expose a young woman or any woman with a pregnancy to the radiation of a CT scan. So it's rare for us to ever order a CAT scan on someone who's pregnant. So as a result, we're sometimes limited to making an accurate diagnosis. And that's compounded further by the fact that when women get pregnant, their uteruses get large and tends to push on other things like the bladder and the tubes that bring the urine down, called the ureters. So women can often have what we call hydronephrosis, or dilation of the plumbing of the kidney, just from the physiology of being pregnant. And a lot of times that can confuse the picture even more, whether they've got a kidney stone or not. So the biggest challenge in women is to confirm that they actually have a kidney stone. But once you're convinced that they do, or the presentation is compelling for a kidney stone, some of the principles are the same. We would probably still give them some time frame to kind of watch their symptoms and see if they would pass a kidney stone. We would probably be more aggressive about preventing an infection. So most of the women would probably be on a antibiotic just to prevent an infection, largely because we don't want to induce any preterm labor with an infection in the body.
Certainly, yes.
The other factor here is that general anesthesia in pregnancy and treatment during pregnancy and how women tolerate a stent, which is one of the products of treating a stone, is also very different. So that would influence whether we would treat things. But that's getting to a very nuanced and detailed conversation. I think the short answer is we would look at a stone in pregnancy as a real concern. We would want to make sure that it's adequately treated and ensure that there's no infection going on. And then we would probably have some of the same principles, allowing someone to try to pass it, again, based on size and how their symptoms are.
Perfect. Thank you. I know it's a very complicated topic, and you did a great job of trying to simplify it for our audience. So I appreciate that. So we're going to take a quick break here. When we come back, we're going to go into a little bit more detail as far as treatment for kidney stones. But we're going to take this short break here. You're watching What's Up Doc on Muslim Network TV, and we'll be back after this short break.
A free 3-minute online chat can give you the personalized tips you need to start boosting your retirement savings today.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for help with food, healthcare, and other resources.
211, how can I help you?
Call 211 or visit 211.org. 211. Get connected, get help.
Dad, they took over my bedroom. Come on, come on. Okay, Dad. 1, 2, 3.
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
We are Justice for All. Headquartered in the heart of downtown Chicago, Justice for All is a global humanitarian initiative dedicated to raising awareness for human rights concerns impacting vulnerable minority groups. Our diverse team of staff and volunteers, led by Imam Malik Mujahid, work tirelessly to help Justice for All achieve their goals. We promote policies that protect religious freedom, address the root causes of mass displacement, and recognize the plight of refugees and forced migrants. Together, we can continue to stand up for justice. Justice for all.
I am what hunger looks like in America. I am an 8-year-old girl who's not excited for the last day of school. Because this may be the last time I'll have lunch.
Till September.
I am a single father of 2 who works 3 part-time jobs,
and that's still not enough to put food on the table.
I was created by artificial intelligence from faces of the 1 in 8 Americans who struggle with hunger.
Feeding America, 200 food banks strong.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
Assalamu alaikum. Welcome back to What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and today we're joined by Dr. Rahman, and we've been talking about kidney stones. So before the break, Dr. Rahman, we went into a lot of detail discussing the different ways to diagnose, one of the best ways to diagnose kidney stones, as well as some complications related to diagnosis in pregnancy. Now that we've kind of gone over that as well as the symptoms, let's talk about treatment. Because I know that, as you mentioned, there's going to be some nuances for different kinds and different sizes, but maybe we can just do a quick overview of the different options.
Yeah, absolutely. So again, we touched a little bit that not every stone needs to be treated. So for patients that we think that they can pass the stone, we will give them a few week time frame to try to pass it, provided they're comfortable, provided they're not showing any signs of an infection. The other forms of treatment really depend on where the stone is situated along the urinary tract, whether it's in the kidney, whether it's in the tube that brings urine down, called the ureter, and how big the stone is, again, whether it's in the kidney or the ureter. So most stones that are in the tube, called the ureter, which is the tube that brings urine from the kidneys down to the bladder, most of those stones are going to be treated with endoscopy, which is a fancy word of saying with scopes, similar to a colonoscopy or any other oscopy that we use in medicine, which means we're going to look inside their bladder and then we're going to look inside that tube with a camera. So there's no cutting involved. It's all with cameras and scopes and wires. And we're going to generally go up and find that stone with a scope and break it up with a laser fiber. Then when we're done, we typically leave a tube called a stent. A stent goes from the kidney to the bladder, and it serves to keep the kidney open and non-obstructed so that urine can kind of continue to flow down from the kidney to the bladder without any problems. So that's one principal way of treating it.
Would a stent be the idea of kind of giving, putting in like support to keep the passageway open? Is that what the purpose of that?
Yes, essentially, yes. There's a couple of thoughts there. Is that the stone itself, again, causes an obstruction. And one of the treatments that need to happen is not only eradicating the stone, but also dealing with the obstruction. The other factor there is that when we go up with the scope to instrument the tube, when we're actually inside of the tube, we're actually creating some trauma to that tube. And as a result, that tube may not be as functional as we like. So urine comes down from the kidneys by an active contraction process. It's not really coming down by gravity. So if we're in there with the scope and we're lasering and we're moving things around, those muscles can be kind of dysfunctional for a while because we've traumatized them. So if those muscles become dysfunctional, urine, there's no way for them to contract and bring urine down from the kidney. So we leave these stents in so that urine has no unimpeded way to come down. And that allows the ureters, the tubes, to recover from a few days from having the stone in and from having the treatment done. But to your point, these stents can also cause some discomfort. They're not the most pleasant things sometimes to have. And we always counsel our patients that you may be changing one type of pain for a slightly different type of pain when you have this stent in place.
Yes, I can imagine. Any kind of foreign object. And so does that stent sit there indefinitely, or do you come back and take that out at a later time?
Yeah, it usually stays in for about 5 to 7 days. It's really just there long enough for us to feel like the obstruction is gone and for that tube to kind of start working normally. Okay. And we usually are able to pull it out in the office.
Okay, great. So the follow-up doesn't need to be another procedure. Or surgery. It's usually
it can be done without anesthesia and without major procedure.
Okay, excellent. So taking a step back, when we talked about our patients who might have a stone that they can pass, I know that there are certain medications that we can sometimes give our patients to help them to pass it. Do you use these? What do you think of them? And what do you think of them if you do? Yeah.
So that's a great question. One thing I want to add to that is there are some stones that you can give medication to dissolve. So not all stones necessarily need intervention. So if we are convinced that a stone is a uric acid stone, for instance, one of the principal ways that we can treat that, as long as the patient is relatively comfortable, is we can give them medication to change the pH of their urine, and they can dissolve the stone. And so that's one thing. Calcium-based stones are not dissolvable. But getting back to your other question, are there medicines we can give that can help pass stones? So there are some medicines that have been studied to help expedite stone passage. A lot of them are drugs that we give older men to help their prostates, like something called tamsulosin or Flomax. There's some calcium channel blockers, which are muscle relaxants to help. The data on this is kind of mixed. I'm not really sure that it helps a whole lot, but the side effects or the downside of giving the meds is pretty small. So we end up doing that quite often. I'm not 100% sure it makes a big difference. The data on there is really kind of sketchy and mixed.
Okay, that's good to know. So it's, again, not cookie cutter, definitely individual treatment based off of what the patient is experiencing in their background.
Yeah, and so one of the other things we should talk about is like stones that are in the kidney. So we touched on stones that are in the ureter,
yes.
But when we're talking about stones in the kidney, we actually open up several ways of treating it. One way that we could treat a stone that's in the kidney, and typically, again, these are stones that are not blocking, but they're big enough that we think they're not going to pass. So then we start talking to patients about, hey, let's try to be proactive with these stones so that they don't cause a problem because they're big enough that you're not likely to pass them. One of the things we can do is deliver shock waves, what we call shock wave lithotripsy. And that's where we center the stone and deliver high energy ultrasound shock waves externally from the outside of the body onto the kidney stone. So that's one way that we can treat a stone that's in the kidney. The other way that we can sometimes use is a more invasive way is what we call percutaneous procedure. And that's a fancy way of saying that we actually make a small incision over the kidney and dilate into the kidney, dilated enough where we can either grab a fairly large stone or we can grind it and suction it out. And that's a more invasive procedure. So I've given you two ends of the spectrum, one that's really non-invasive and kind of an outpatient procedure where patients go home right away.
Yes.
And the other is a more involved procedure where we're actually making a small incision, more risks of having problems and bleeding, where the patients will need to stay at least in the hospital one night. And then the same type of endoscopy that I described where we go up with the scope, we can also employ that type of procedure for a stone that's sitting in the kidney. So there's at least 3 different options we have for stones that are in the kidneys, typically that are not blocking anything, but they're big enough that we think that there's going to be a problem either with pain or infection down the line that we need something done sooner than later.
Excellent. Thank you for being so thorough in that coverage. So options, again, it's going to be based off of the individual as far as treatment. And I imagine because it's so common, it's a commonly seen problem that urologists are well versed in all of those different treatment options that you mentioned.
Yeah, I mean, most of these urologists are well versed in. Sometimes the procedure where we go in with a small incision is a little bit more specialized because it requires a little bit more technical skill. But it is something that well-skilled and well-trained urologists, and I would put myself in that category, would be well-versed to do.
So if you're lucky enough to be in New York, New Jersey area, then Dr. Rahman is your guy.
Thank you so much. Appreciate that, Dr. Aalia.
So I guess we've come now full circle to talking about prevention. And we kind of touched on this at the beginning when you talked about risk factors, because some of the risk factors outside of genetics have to do with lifestyle, diet. And so you explained very clearly that hydration is so important. And so let's talk about maybe some other things that you didn't mention earlier that we can either prevent them from forming in the first place, or for patients who are more prone, know that they've had one, because I know that having a stone in the past is a risk factor for having another one. So prevention. And then if there are any supplements that you recommend, I know that you don't recommend a lot of calcium, but are there things that you do recommend for patients who may be more at risk?
Yeah, that's a great question. So one of the things that we often do is we do study the chemistry of patients who've had multiple stones or large stones. So we do a metabolic, what we call a metabolic workup, and that's essentially where we study the urine chemistry of the patient, and we see where there's an imbalance. We see whether they have too much calcium, not enough citrus, too much oxalate. And sometimes we also check their blood to see if their uric acids in their blood levels are high. Or we haven't even touched on parathyroid hormone, which is the hormone produced by the parathyroid glands right here. And sometimes that hormone is a little bit out of whack, which is important for calcium metabolism. So there's a whole other area about studying the patient's metabolism that helps us decide these things. But in general, if we've tried to counsel the patient regarding how to prevent the stone, but they seem to continue to make the stones, and we have a good idea of their urinary chemistry, we will then start talking to them about going on medication and sometimes supplements. Sometimes there's an overlap between the two. So a lot of times, even after counseling, patients can't get enough citrus into their bodies to make a big difference. So a lot of times we will put patients on potassium citrate as a supplement or as a medication. And that allows their body to get enough citrus in their body to help get them to the levels they need to prevent a kidney stone. If we find that their uric acid levels are really high, and despite our best management, they can't bring that down despite trying their best with their diet, or if they have some underlying GI problem that's preventing them from doing that, a lot of times we put these patients on allopurinol, which is a drug which helps to break down uric acid before it gets into the urinary tract. So those are the two big things that we use. A lot of times, if we see that the calcium levels are way higher than we like to see, and again, we've eliminated the supplements and we've checked their hormone profile with their parathyroid hormone and everything is in check, and their calcium levels are still out of whack, particularly in their urine, then we'll sometimes put them on some diuretic type drug, which helps them not spill as much calcium in their urine. Typically, a thiazide type drug will help us to not spill calcium out of the urine, help to reabsorb some of the calcium back into the bloodstream and not spill as much out of the urine. So those are the principal drugs we will use if we have patients that are ongoing stone formers.
Excellent. Excellent. Thank you so much, Dr. Rahman. A lot of useful information, not just for our audience who may be potential patients, but really for any clinicians out there, because I definitely have learned quite a bit through our discussion today. So really thank you for your time and sharing your experience with us. We wish you every success in your future career.
Thank you, Dr. Aalia.
Absolutely. Thank you for joining us on another episode of What's Up, Doc. You can watch this as well as our other episodes on our website at muslimnetwork.tv and on our YouTube page at youtube.com/Muslim Network TV. We're also streaming on Roku, Galaxy 19, Apple TV, and Fire TV. So I hope you'll watch some of our other episodes, and I'll see you next time. I'm your host, Dr. Aalia Al-Barwani, and I'll see you on another episode of What's Up, Doc.